TopMedTalk.
Well, hello and welcome to TopMedTalk. We're in Denver, Colorado for the SOAP meeting, the Society of Obstetric Anesthesia and Perinatology. I'm Desiree Chappell. I'm your host for TopMedTalk and co-editor-in-chief. And joining me today is the founder and former co-editor-in-chief and editor-in-chief, Monty Mythen.
I'll take anything I can get, Desiree. What is it at the moment? Former editor-in-chief.
Former editor-in-chief, I think is what we need to go by. Monty, you are former because you have left us.
I have left you. So August last year, I joined Edwards Life Sciences as an employee, having finished at the university and in the National Health Service. And we concluded it was too much of a conflict of interest. Yeah. So they said, no, please, Edwards said, no, please carry on. It's very important work. We don't get paid for it, for open access medical education. But to be editor-in-chief,
probably
too many conflicts. So Mike Rocott's taken over.
Yeah,
along with you.
And we love Mike. And he couldn't be here with us this weekend. So you graciously said, you know what? I'll go ahead and join you. Help carry the load.
But I clearly have some potential conflicts of interest.
You do. And that's okay. You know, Edwards Life Sciences, we want to thank them. We want to thank all of our sponsors, actually, who have been able to make TopMedTalk free and open access to the world. Edwards Life Sciences being our founding sponsor.
Yeah. Absolutely. And we couldn't have done it without them and our other sponsors. Mm-hmm. And also from the point I'm still an emeritus professor.
You are?
I still need to keep that bit up. I'm an adjunct professor, Duke in the USA. Yeah. So I still play by the rule book.
Yes. Yeah. And we also wanted to thank SOAP for having us here this year at their meeting in Denver, in the exhibit hall, giving us a great booth right here in the center of all the action. And it's been fantastic to meet the leadership within the organization. If you don't know much about SOAP, please do check them out. They're an incredible group of people doing some really cool things.
And there's lots of cool kit.
There is very cool kit.
You know what? It's all about the epidural space. That's not fair. Almost everything is about the epidural. There's lots of cool kit, though.
There is some very cool kit that I don't think we always get to see. So, check out the list of all the different folks that have been here this year. It's really cool. So, well, Monty, whenever we go to meetings like this, we have the incredible opportunity to sit down with, the presenters, some of the attendees, and hear about what's going on in the space where we are. And so, luckily here, this year, we're hearing about obstetrics. We all know maternal mortality is in the news everywhere, specifically here in the U.S., but it's not just here. That's something that is a concern around the world. And so we wanted to take an opportunity to deep dive with a couple of the attendees here who are doing some really cool project work in the space. So our next guest is Dr. Andrew Geller. Andrew, thank you so much for joining us.
Thank you for having me.
Yeah, so for those who may not know you, why don't you tell us a little bit about yourself, where you practice, type of anesthesia you do?
Sure. I started at Cedars-Sinai as a resident now 16 years ago, and have had many opportunities to be involved with technology in the healthcare space through roles in the enterprise information systems of our hospital, as well as basically get to explore lots of physiology in different anesthesia spaces. And that's really what attracted me to anesthesia as a medical student, was the immediate feedback you get from what it is that we do to take care of patients and the thrill of the resuscitation. So I did a fellowship at OB anesthesia in 2013. I finished and have now been director of our OB anesthesia section since, I think, 2020, where we've been able to grow our subsection as healthcare has changed through those challenges, and have really put a lot of effort in doing our best to reduce mortality and morbidity related to the OB care, as maternal resuscitation has always been a passion of mine.
Yeah. One reason I love anesthesia is that you give a drug, you have an immediate response, everything's really fast moving. It's not like that at home. Like, you can tell somebody to do something. I don't always do everything I ask them. There's no immediate response.
Are the consequences any different?
Yeah.
I know you verbalize it as though the consequences are similar.
Yeah.
But they're not, are they?
No, not so much. Well, that's fantastic work that you've been doing. What are some of the research interests specifically that you've been working on?
So the OB population, the hemodynamics are very, very different than what we get exposed to in other operating rooms or care that we are able to provide. With the OB population, it's generally thought of a happy, healthy place.
Happy anesthesia. That's what
right. And that attracts a lot of people. But when things aren't so happy, it comes as a surprise. And I think that's where our work is most important, to make sure that babies and newborns get to go home with their mother. The whole space really hasn't been studied on a very granular level, mostly because a lot of the work that's needed to be able to understand it has to be invasive. And a lot of the moms who do come for delivery and do provide or do request anesthesia services, we want to keep this as minimally as invasive as possible. And we're here to take away their pain, not be more active with it.
So if I could dig into that a little bit, because we were touching in the pre-conversation that Cedars-Sinai, where you work.
Yes.
Many of us around the world have heard of Cedars-Sinai, because that's the place in Beverly Hills where the water star is. I'm sure, and I visited there in the past. I know it's a bit more complicated. But it's also the home of the Swan-Ganz catheter.
Correct.
And, the purpose for stating that is that using pulmonary artery catheterization guided by fluoroscopy preceded the balloon flotation technique.
Mm-hmm.
But until relatively recently, that was the way that we could try and evaluate human cardiovascular performance. And we did it in cardiac, we did it in certain major surgeries, we did it in certain experiments, but always deemed to be rather too invasive and possibly dangerous to start to do it to mums with babies.
Correct.
Yeah, which I think is fair, very fair. Which means that the explorations we did in sepsis, for example, and the explorations we did in adult cardiac, congenital cardiac, etc., we've not done. I'm restating what you said. We haven't done it in the mums and babies because we didn't have the tools.
Right. And my training and early part of my career has been very much and with a lot of interest in the Swan-Ganz and the ability to get that data and numbers. And my previous, before becoming director of OB anesthesia, was in liver transplant, where swans are used all the time. And that's just the way I was trained, and never really got the same exposure to use of ultrasound for hemodynamic monitoring. And my continues, as that has grown in my clinical toolbox, the use of Swan is still my background. And as the generation change has now occurred, most people don't have that exposure. Right. So I'm still a big proponent of the Swan in those numbers and utilizing it for care.
And we should probably just decode the Swan a little bit. So Desiree, you've put hundreds or thousands in over the time. Very, very briefly.
A lot.
For an adult, for example, undergoing cardiac surgery, you put a big pipe in the neck in a vein. Yeah. It's a pretty scary big pipe if you haven't worked there before.
It is.
Like a McDonald's drinking straw. Other drinking straws are available. Yeah. Goes into the neck, down to the top of your heart.
A lot of times we're putting that part in whenever our patients.
And then you feed through this narrow but long, snaky looking thing, and it goes through the heart.
All the way through.
To the pulmonary artery.
Which you tickle it.
So we get used to that and think, oh, that's okay.
Yeah, no big deal.
But if you say, hey, mum, do you fancy having one of these in while we have a look at you while you're having your baby? Not sure about
Not so much.
With a lot of tape and wires added to it.
Yeah.
A lot to go wrong.
And by the way, you can't walk and move around with it.
Right.
And it's going to get, snagged and pull on the stitches and stuff like that. Yeah.
Anyway, moving on. We put them in context.
In the world of anesthesia and obstetrics, we hear about maternal mortality. And this is a theme that is, people are talking a lot about here at this meeting and in the news. And when we do, we feel like as team anesthesia, what is it that we really contribute to this? I mean, in our world, we're always thinking about airway disasters. I know we were listening to some lectures yesterday that was talking about, really focusing on airway. But in reality, there's a lot of hemodynamic changes that happen for the obstetric patient. And then I've done a little bit of OB, but that's where I feel like a lot of the challenges are and that we may have an impact on that.
Oh, absolutely. I mean, we're there to resuscitate. So whether it's the airway, the cardiovascular system, the volume status, at the end of the day, the goal is, can we get oxygen to the organs that need it? However we go about doing that is where we fit in and play that role, whether it's giving blood to the patient, giving medicine to make sure that their blood pressure or their cardiac output can still perform that function of being able to get blood to where, or the oxygen to where it needs to go.
I just reflect on the airway for a moment, because for much of my career, the failure to secure the airway in a timely fashion was a major driver of maternal mortality. Because the mum's airway, if you're doing a general anaesthetic, is complicated for very different reasons we don't need to discuss. And when I was early on in my career, the next thing you could do was try harder, if you see what I mean. There was no additional tools and devices, whereas they've flourished in a way that now the airway problems seem to have virtually disappeared. Is that an unfair reflection?
Actually, OB all the time, but
as a cause of mortality, you don't see them as often.
Yeah.
It's still a problem, but there's lots of solutions.
That and the push because of that concern to do a regional anesthetic over the years has also shifted most clinicians away from airway management being needed in the first place.
Yeah.
So with more epidurals and spinals being utilized for either care or delivery or treatment, the need for the airway manipulation has gone away.
So mum's awake, and if you do have a problem with the airway, you've now got a big cart full of tools. We've done many podcasts about it. Great, really fantastic tools that have been
that has helped immensely.
Adding video to it, adding different ways of visualizing the airway, such that it's still a challenge, as you say, but it doesn't usually results the cause of death.
Correct.
So the hemodynamics seem to have gone into the mainstream now as being the main cause of death.
Correct.
And we haven't had so much visualization into that piece, right? I mean, traditionally, for those who are listening that may not know, I mean, it's a very traditional pulse oximetry and a blood pressure cuff that monitors blood pressure during the case in EKG.
Correct.
But we talked to Dr. Orlando earlier about the barriers to and issues and challenges with doing a traditional blood pressure cuff for this particular patient population.
Right. And depending on where we're talking about in the process, the baby also acts as another monitor when you monitor their heart rate, because that heart rate variability and where their heart rate sort of lives is an indication that the baby's getting enough oxygen from mom. So when that deteriorates, it is also could be a hemodynamic issue related to mom.
So we go back 30 years ago, we had the blood pressure cuff, automated blood pressure cuff, and some other monitors. We had a degree of baby monitoring. We'll come back to that in a second. And we had the try harder with the laryngoscope.
Right.
The try harder with the laryngoscopes jumped on in leaps and bounds. Has the monitoring the baby bit changed?
Only in the idea of it being now wireless to some degree, and the wireless connectivity piece of it is still even a challenge.
Not great.
Yeah.
But for most people, the blood pressure cuff is still exactly the same as 30, 40 years ago.
Correct.
Talk to us about some of the challenges that you've seen and where you think we're advancing within this space.
Getting back to not having easy access to being able to monitor the other hemodynamic parameters, there's been this dogma that blood pressure is the primary hemodynamic variable that we are using to treat and intervene when necessary. But there's delays in obtaining that data, and it's, at the end of the day, not all about the pressure. It's how are we getting that oxygen to the organs that need it. And that delivery is all dependent on flow. And without knowing what the flow is, the next best tool that's not invasive is the blood pressure. But at the time, 30 years ago, when that became available, that's all he really had as sort of that surrogate of what the flow might be. And over the time, clinicians have sort of developed their own clinical intuition and understanding how to translate those pressures into whether or not the oxygen delivery is actually occurring.
Can you remind us about the mum's blood supply to the baby? Because, I mean, if those of us who are clinical or have done human physiology, we kind of get the fact that the brain has auto-regulation.
Correct.
If you maintain a critical level of pressure, you maintain flow.
Correct.
There are other parts of the body that behave differently. There's a sort of hierarchy. Where does the center sit in that?
Sure. So the maternal blood will pick up oxygen as it normally does in the lungs, and that gets pumped by the heart via the cardiac output to the uterus at a rate at term pregnancy of about 700 mLs per minute. So it's a large percentage of the overall cardiac output, especially when they're not pregnant. And the reason for that is the uterus itself does not have the autoregulation ability. And the supply of oxygen from mom to the baby at the level of the uterus has to transfer across the placental bed, which then gets picked up to be transferred. So when there are slight changes in maternal oxygen availability, deliverability, pressure, flow, etc., without the autoregulation, that O2 supply getting sent to the placental bed can be diminished. And when that occurs, the baby doesn't do well and can lead to other morbidity or mortality issues to the fetus.
So when I'm trying to work out what to do on the hoof, I think someone's in real trouble. Their blood pressure's dropping, they're losing consciousness. I give something to try and restore blood pressure and they may wake up again.
Right.
If they're slightly hypovolemic, for example, I've probably lost blood supply to the gut and to the kidneys, but it's a trade-off.
Correct.
Where's the baby in the hierarchy of those other bits that are giving up to save the brain?
Right. So it's still going to be mom, maternal brain, heart, first, because they still have that autoregulation. Without that blood supply that would normally head to the uterus is being shunted up to the heart and the brain. So that's why I think it's critical to be able to understand and see those potential changes, because your ability to intervene is far more limited without that autoregulation piece.
So what we had in the past was blood pressure. Well, actually, blood pressure is measured intermittently. So probably if the mom was conscious, consciousness was lost.
Correct.
There's a route in between that of not feeling very well, etc.
Right.
Consciousness is lost, and somewhere on that path, if the baby was being monitored continuously, the heart rate of the baby would change.
Correct.
And those were the clues you had.
Correct. The blood pressure also becomes difficult to even obtain non-invasively with the cuff, especially in the lower range. So it's sort of the clinical signs that are left as to what clues us in.
Yeah, absolutely. Well, walk us through. You've been obviously doing a deep dive on this and really passionate about and interested in it. What are some of the things that you're working on right now to study that? How are we looking at this and determining flow? I mean, I know we've talked about some monitoring technology, the hemisphere, and using different products, but talk to us a little bit about that.
Sure. Because the space was so dependent on invasive monitoring, the development and the availability of a continuous non-invasive cardiac monitor came to us via the Acumen cuff, which is a device that is a miniaturized blood pressure cuff that sits on the finger and can extrapolate blood pressure in real time, beat to beat, off of the pulse. It is able to also then give us stroke volume as well as SVR and cardiac output with some other parameters. But at the basics, that's really what we need to understand to be able to, one, detect, and two, intervene. But if we go back to the physiology of what components make up blood pressure, it's not just a number. It's coming from what is our heart rate, what is our cardiac output, what is our stroke volume, what is our SVR. If you want to even take it the step further, when I was talking about it's all about the oxygen delivery, well, that's all cardiac output dependent. So without those numbers, we're sort of just take a large approach to, well, let's just treat it all, or we're going to treat some of it and hope that we get the response we want without knowing what components can be targeted and individualized, for that matter, to each patient. So this device has really allowed us to, one, look at and pick up and intervene at the right time and the right variable that the patient needs.
So say, I mean, because you're kind of saying, I'm either going to use a vasopressor or fluids, and is that the right, or another?
Right.
Is that the right option?
Correct.
When you bring a junior colleague with you or someone you're training and you have cardiac output monitoring of this form for the first time for them, what are the sort of aha moments that they have? Are they surprised they give more fluid? Or are they surprised they give more inotropes? Are they surprised they give more pressors?
Oh, all the time.
Yeah.
Yeah. I mean, I sometimes will blind them to the device and say, all right,
By the way, the mum and the baby have been well looked after.
Yes. Yes, this is if everything is status quo, or I'll ask them to even predict, because in the anesthetic administration for C-sections, for instance, with a spinal, there is a rapid decrease in SVR and therefore translates into a decrease in blood pressure. And I ask them to predict, what changes do you see, to what degree, and see how far off they are, because it's very hard to generalize and predict for each patient how they will respond. But it then hammers home the point that, well, you also don't know that you can't, how to treat it and to what degree you're going to treat it without that real-time objective data available to you. So we started with an interesting QI project with the ability to use this non-invasive blood pressure cardiac output device to see the variability in our patients when they come for their scheduled C-section as to where they are in terms of their volume status, as that is an important factor in how far of the hemodynamic changes they see after spinal administration. So getting a baseline on their hemodynamics, and then for taking it a step further and being able to understand, well, how are they going to respond to a fluid administration, to be able to then give us insight into, well, yes, this patient is very far behind in their volume status versus, no, this is adequate.
And I'm sorry to interrupt there, but we know this, but just so everyone out there is with us, that evaluation of the hemodynamics is using the monitor and putting something on that looks like a pulse oximeter probe.
Correct.
And how long is it until you've got the hemodynamics? So it's just the probe goes on the finger, and then it's
right. It's almost immediate.
Okay. So a minute later.
A minute later you can start collecting the data, and because it's beat to beat monitoring and data interpretation, you see the changes of any intervention within seconds, which is key to an individualized approach at the right time with the right intervention.
And I think you presented a paper here today.
We did.
How did that go?
It went well. It generated quite a bit of questions and interest. Pleased to see that. We're seeing a lot of emphasis and interest on the fluid versus pressor management. And the trend seems to be, how do we narrow the administration of these, but yet at the same time try to generalize it? And I think where this device that we've been using is going to be key is that not all our patients are the same.
Yeah.
Even if they are, quote unquote, healthy full-term pregnancy, there are a number of factors that may change where they're starting from or how they respond to what we provide.
But certainly the early days of the adult goal-directed fluid therapy,
correct,
it would come out to be an average of about 600 mils, for argument's sake, very reliably.
Right.
And people would say, so the answer is 600 mils.
Right.
So no, you need to look at all of the patients, because the range is 250 to 2.5 liters.
Right. And with a range like that, I mean, you don't know. So, I mean, you can fly blind and develop your clinical insight through clinical experience, or you can have the data and the numbers to be able to utilize.
What do the results show? There are a few little twists in there.
Yeah.
Give us the big picture and then get to the twist.
Sure. So the preoperative variability was definitely there. And what we did was we ended up tailoring our fluid administration prior to spinal administration for the C-sections based on how responsive they were to a fluid challenge in pre-op. What we found was those patients that when the approach to the fluid was individualized, we ended up not only with what was expected with lower nausea vomiting episodes, lower hypotension episodes. These patients did end up getting more fluids, but overall, they seemed to have more urine output, and they what was interesting was their QBL was very different than QBL, quantitative blood loss. So in the surgery, they will weigh and measure all the blood that is collected instead of just a visual estimation of the blood loss. So that value tended to be lower than the patients who just got a standard administration of volume, which were probably under-resuscitated.
So when I read that, thinking back to research done in the last century, I thought, oh yeah, that's what I would expect.
Right.
How have people reacted to that?
Some the same and some are surprised. The hemodynamic control piece of it, I think, was expected, and it's like,
But
well,
the bleeding
bit, yeah, that caught some people by surprise in the sense that oftentimes more fluid is can be detrimental to that, especially when you look at coagulation ability of the blood or overall tissue perfusion, etc. I think that the key here, and it does need further exploration, is we need to do a better job of individualizing the approach to the patients to what their body needs and handles at the right time.
So, and just because I want to just get the hypotheses out there for people to think about. So where are you with those?
Yeah, I mean, one thing I was thinking about was if cardiac output delivers oxygen, it also delivers medication and hormones. Mm-hmm. So after delivery, the uterus normally will contract based on the mom's ability to make Pitocin, but then we also give extra oxytocin. Presumably, especially without the autoregulation that the uterus will see, that drug or hormone needs to get to the uterus. But if we're under resuscitating our patients, our cardiac output may be too low to get the stuff to the receptors when it needs it, especially in a C-section where the majority of the surgical technique of the obstetrician is to take the uterus outside of the pelvis and flip it up, which then will constrict the uterine artery vessels, which may limit the Pitocin delivery. Just a very high level theory, correct. And it also highlights the idea of, well, you're constricting those vessels, the pressure will go up, but I'm not getting enough of my oxytocin to where it needs to go because the restriction is there.
And I'll shut up in 30 seconds. If we go way back to when I was doing a bit of research in this space, I was reading the literature.
Mm-hmm.
Better end organ perfusion is associated with less contact activation, with less stimulation of procoagulant pathways, sets up less of a sort of DIC type of state. Your crystalloid, I think, was lactated ringers.
Yes.
Which in a thromboelastography is procoagulant.
Right.
And if you get that slightly wrong, that creates a little bit of a sort of mini DIC type of state as well. So there's lots of theories. They're all theories, folks, by the way. There's no proof in this.
Right.
But it's not a crazy finding.
Right. Right. And
it may be true.
Right. Yeah. And now we may have some objective ability to prove it.
Wow. No, my head is swimming to like all these ideas and thoughts and working with the physiology, pathophysiology. Yeah, all theories. Yeah. But I mean, it's fascinating. And it's really fascinating research. What are some of the other bigger questions that you got during your session today?
The compliance part of it, the hard part, there's so many moving parts and the high anxiety and emotion with mom being prepared for a C-section that sometimes fluid administration and taking the time to make sure that the fluid administration prior to the spinal, vasopressor administration prior to spinal has been taken care of. Whether this device just being utilized as new or change in workflow, the personalization piece helped refocus the need for administering these fluids, and I think improved our compliance for that reason. Was, okay, it's not just, all right, here's just 500 cc's, let's just move on with it. No, it's, wow, I'm actually giving it for a reason and it's tailored to what they need.
Yeah, and I'm looking at your response to what that's given.
And the patients are actually very pleased with that. And it's like, oh, you're taking the time to pay attention. Oh, this is going to give me more information about what's going on. Yeah, please let me use it.
Yeah. Did we talk about the specific patient population that you looked at?
So this project was our scheduled C-section population. It was just as they were scheduled, we did them.
Okay, repeat or not, could be first.
Could be anything, yeah.
Okay.
Yeah.
All normal hearts, no growth, congenital?
Not that I remember.
Yeah.
There may have been one or, no, I don't think so. I think I used it for those patients elsewhere.
Okay. We're getting ready at one of the sites that we're working in, getting ready to start an OB project I'm really excited about. And the team, we're used to, a lot of the team that's there has worked in the main OR, and we have utilized the technology, HPI and Acumen in the main OR. So it's going to be really interesting. About half and half of the team have used it before and half haven't. So getting it up there in the OB suite and realizing, where we have the potential to use this and then tracking onto those patients and linking it out in the long term is going to be good. Any words of advice for us?
I think once people see it, they like it. The interesting thing is the HPI piece with the OB is going to be different, because after the baby's delivered, we do see, that's when we see a large change in volume status. And it is expected that our HPI we would expect the change in the HPI, but we don't necessarily see it because the device doesn't know that that's what's happening surgically.
Yeah.
But there was that component. And then the other piece of it was, I believe there was a bit of the HPI piece was also helpful in actually predicting or helping as an early warning to impending hemorrhages. So one of the interesting things that we did with part of this QI was we kept the monitor on the patients in recovery. And we did see these hemodynamic changes, including HPI, in patients who basically had atony, where the uterus wasn't contracting and was accumulating blood before that blood was recognized as being expelled, and the patient had a hypotensive event.
Yes.
And so then it was, okay, wow, this is being able to show that before the actual bleeding becomes externalized. So there's probably an opportunity for this as used as a early indicator of postpartum hemorrhage.
It's really interesting to hear, because I'm now, a big fan. Obviously, I work for Edwards Life Sciences. So Edwards Life Sciences technology, one of the reasons I joined the company, but I was very, very skeptical about its ability.
Yeah.
And sure, it's been very validated now. We've addressed all of that. But I keep saying to myself and my colleagues, we can't assume it's going to work in every different form of physiology, because mums are very different.
Correct.
But it's reassuring that it does seem to be signaling.
Right. I mean, the non-invasive blood pressure cuff is very old, basic technology.
Yeah.
And
the Finapress originally.
Yeah. Oh gosh, that's going with that.
So the fact that we now have something way more advanced is better than just relying on this intermittent Q15, and especially in recovery, ability to do that. And it breaks out that blood pressure into the individual components as to what's going on.
Yeah.
The thing I say to people, which I think we're all agreeing with, is you've got to learn by doing.
Yeah.
Because this is very novel areas that we're going into.
Yes.
And you can't learn by social media, and you can't learn by reading other people's literature. You've got to get to a point where you've got to learn by doing, and it's a rapidly developing field.
Right. And this population, which is going to be different than the OR, can compensate for a long time.
Yes.
So oftentimes, they could have blood pressures in the 70s, and because that cuff doesn't cycle for 15 minutes, we may not necessarily know about it. In this case, we start seeing stroke volume or SVR changing with an increase in heart rate to maintain that cardiac output. We see those changes in real time, and that's where it's still helpful, especially with the uterine atony postpartum hemorrhage events, in terms of sort of being an early detector of that.
Fascinating. Congratulations. This is fantastic work. And
Thank you.
Thanks for spearheading into this new world, a whole new world in this space. So fantastic work.
Thank you. And thank you for having me. And thank you for Edwards with this device and being able to explore and do better for the moms out there.
Yeah, no, well, just in closing, find out, what's the next study you're going to be doing?
Sure. So the next step is now that is using this in our labor epidural population, because again, it's a space where you have changes in SVR, you see compensation, but there's also the baby is yet to be born. So right now, we still rely on blood pressure to sort of resuscitate when the baby's in fetal distress and the fetal heart rate goes down. But I'm fairly certain that there's a cardiac output component to this that we're not picking up. So now having that ability to trend and see those changes and the parameters that change the cardiac output does that correlate with fetal heart rate changes, and what components are compensating for those that don't have a change in the baby, as well as is our intervention to resuscitate baby can now be broken out to the parameters that are needed that are being displayed by the Acumen cuff.
Wow.
So we've started that project, and hopefully we will be able to have fairly confident, meaningful results shortly.
Wow, that is
Brilliant.
yeah, that is brilliant. Absolutely. Well, thank you again for taking the time out of the meeting. I know you're super busy here, but we really do appreciate that, and can't wait to hear the next project, what's going on with that. So
Likewise.
hopefully we'll catch up soon. All right. And thank you for listening to TopMedTalk. You can always find us at TopMedTalk.com. We're on social media, LinkedIn, Facebook, X. We're there. And YouTube as well. We have videos up there. All of our podcasts are also there. So if you're finding us on YouTube, please give us a thumbs up, subscribe to the channel. Every little bit helps us. And just thank you so much for listening. Have a great day. We're going to have more from SOAP over the next couple of days. But anyway, have a great day. Cheers. Bye.
TopMedTalk.
Thanks for downloading TopMedTalk. Don't forget to subscribe. Check us out on YouTube and, of course, on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.